Hi there, my name is Rob and today I'll be discussing with you chronic obstructive pulmonary disorder, or termed short COPD. Now the World Health Organization, as well as systematic meta-analysis by Menino, Soriano, Adaloya and other collaborators, had found the definition of COPD as a preventable and treatable disease with some significant extrapulmonary effects that may contribute to severity in individual patients. The Global Initiative for COPD, which is a major global collaboration between nations, has also termed COPD as a mixture of airway disease, parenchymal destruction, and a lack of airway responsiveness leading to, for example, asthma or emphysema. It is a leading cause of morbidity and mortality in countries of high, low, and middle income, and estimates showed in 2001 it contributed to 3 to 8% of total deaths, and it was the sixth leading cause of death in nations of low, high, and middle income. The pulmonary component of COPD is a restricted airflow that is partially reversible by medications. The limitation is progressive, associated with abnormal inflammatory responses of the lungs to gases and particles. COPD was the 7th and 10th leading cause of disability-adjusted life years, that is, the life years that are lost as disability caused by this condition. There are stages of COPD, and these are defined as mild, moderate, severe, and very severe. Mild being a chronic cough, sputum production. Individuals are usually unaware of this. Moderate being a shortness of breath, depending on exertion, a presence of cough and sputum. This is where medical attention is first sought. Severe, which is greater shortness of breath, reduced exercise capacity, and repeated exacerbations which directly impact the patient's or the person's life. And very severe, which is effectively chronic respiratory failure followed by death. Now, as a stark contrast, I've chosen this because my father suffers from COPD and has so for the last 25 years, and so it is a personal link, but also the fact that my thesis that I'm writing currently is in respiratory health, and I thought it a good idea to maintain that interest in the area. Now, chronic respiratory disease is among the leading causes of mortality, as I've said, and morbidity worldwide. It is currently the 4th most common specific cause of death and predicted to be the 3rd by 2030, as defined by Adaloya and colleagues. The problem of COPD and why it's so important is that it coexists with other comorbidities, which presents a growing problem globally, especially with the number of ex-smokers amongst the world population and the indirect and currently direct effects on our populations. This highlights the importance of increasing our understanding of the broader psychosocial, but also public health and population health impacts of COPD. Now, the disease prevalence, burden, and risk factors are as follows. The WHO, or the World Health Organization, estimated the rates of COPD at 385 million cases in 2010, dropping to 174 million in 2015, again defined by Menino et al. Deaths from COPD are 8 times higher than asthma, and the standard age disability adjusted life years per 100,000 was highest in 2000 in PNG, India, Lesotho, and Nepal. So it's a worldwide problem that doesn't just affect one demographic index of people, but many. Death rates steeply increase with age, and that's a stark fact of COPD. 3.2 million people died of COPD worldwide, and that's an increase in 116%, despite the age standardized death rate of 41% in 2010. COPD is higher in high-income countries. This is due to the prevalence of smoking among the population. And between 2000 and 2010, there are 4 to 10% of adults that were diagnosed with this non-reversible progressive version of COPD. That it contributes to 38.6 billion euros, or 3% of total EU expenditure as defined by the WHO in 2010. 73% of COPD deaths are related to smoking directly. Now, the risk factors as found by the GBD project collaboration, the World Health Organization, Menino et al., Soriano et al., Ambrosini, and Adaloya and colleagues had found that these were the risk factors predisposing to COPD diagnosis and development: genetics, tobacco smoke, indoor pollution, outdoor air pollution, occupational dust and chemicals and fumes, as well as infection, biological markers of oxidative stress, socioeconomic status, and inconclusively asthma. Now, the differences in worldwide trends seem to affect the Americas the highest, with the highest degree of prevalence, with the lowest degree of prevalence surprisingly in Southeast Asia. Africa suffers from high degrees of prevalence. However, the Middle East and Arabia are yet to be defined, as not enough data or collected surveys has been collated from these regions. Prevalence amongst men was consistently reported higher than women across all world regions, settings, and income categories. So this was completely independent of socioeconomic status. Now, factors associated with the disease in low middle income countries include a lack of COPD awareness, a lack of education, challenges of the political system, the government, industry, and funding, as well as pharmaceutical companies. Now, governments play a large role in educating the public regarding COPD development. Now, urbanization and environmental protection are another couple of factors that play a large part, including how tightly industry and factories are built to their cities, how close proximity people live to one another, whether there are indoor biomass sources, things like that. Environmental protection in terms of poor indoor housing quality. These are modifiable by cleaner and greener energies and control via regulations and government legislation. Now, there are strategies for intervening in COPD, and quickly these are primary, secondary, and tertiary interventions. Primary being behavioural individual approaches such as cessation of smoking, secondary being screening of affected populaces, and tertiary predominantly medical treatments, surgical treatments, diet control. There are some limitations that exist with this data presented. That is to say, there's no main consensus on a standard definition. There's a lack of spirometry data and surveys globally. There's a lack of routine COPD data collation, especially in the Middle East and Africa, and the age of examinees of the epidemiological models do not incorporate the socio-economic impacts of study sites, income levels, and other comorbidities. Thank you for listening to my talk.